Welcome to another webinar by InVivoQ. I'm Sean Tong, the Business Development Manager for InVivoQ, and today's topic will be on humanized mice in oncology. So this will be the agenda for the webinar. I'll go through the current treatment landscape of oncology and discuss a paper on the use of humanized mice in the context of anti-tumor potency of PD-1 and TIGIT co-targeting in CD56 NK cells and CD8 positive T cells. I'll follow this up with an application of the humanized mice technology in the field of oncology, as well as provide a perspective and summary of the webinar. So now I'd like to briefly talk about the current treatment landscape of oncology, as well as some of the considerations when developing treatments for oncology. So cancer is a relatively common disease. This affects up to or more than 20 million patients per year, as reported by the Global Cancer Statistics. So the most common cancer types are breast cancer, prostate cancer, lung cancer, colorectal cancer, and skin cancer. Quite a few of these cancers do not have suitable treatments. This is also because of the way that cancer can mutate unpredictably, and it's very hard to sort of develop a therapy that would be able to target all forms of cancer. The gold standard for cancer has generally been surgery to remove the tumor tissue, followed by chemotherapy to sort of reduce the existing tissue, the tumor tissue in the body. Radiation therapy is also targeted towards the tissue to remove existing tumor tissue. And in certain cases, transplantations to sort of repair the tissue that was damaged or lost as a process of the cancer. So more recently, developments in the field of oncology have geared or moved towards immunotherapy, where it uses, let's say, the immune cells of the body to sort of target the cancer. In this way, it's more targeted, it's more specific as compared to, let's say, chemotherapy or radiation therapy. And so the side effects that you see in immunotherapy-based treatments for cancer is that there are generally less side effects if the immunotherapy is more specific. So when we talk about cancer immunotherapies, they fall into a few different categories, such as checkpoint inhibitors, adoptive cell therapy, vaccines, and antibodies that target specific aspects of the cancer, for example. So in adoptive cell therapy, such as CAR-T or CAR-NK therapies, these leverage the immune cells of your body to target the cancer by taking them out of the body, engineering them towards recognizing a particular cancer or in the specific cancer within the patient, and transplanting them back into the patient so they can recognize the cancer in that case. So newer approaches to the development of CAR-T and CAR-NK cells have started to involve the engineering of the cells within the body, as opposed to taking out the cancer cells and engineering them. So this skips a step of needing to take out the immune cells and engineering them when you can engineer them in the body itself. But of course, this is an area of active research, and there's ongoing developments every day. So when developing an immunotherapy for cancer, there are a few things that need to be considered. In the presence of, let's say, a lack of an immune system, as most cancer therapies are tested in immunodeficient mice, there are potential issues when you test your therapy in immunodeficient mice. For example, if you were to take a tumor and put it into an immunodeficient mice, there is a possibility that the tumor would develop very, very differently from how it would develop in a mouse with an immune system, for example. So the expression of checkpoint inhibitors, as you can see from the graph over here, can vary very differently depending on whether it's inside an immunodeficient NSG mouse or a human immune system high mice. Because of this, some of the therapies that work on immune checkpoint expression may not perform as you would expect them to in an immunodeficient mouse, for example. The characteristics of the tumor can differ very greatly, and as such, the therapeutic response can also be very different. So, an additional consideration that might be needed to be taken into account would be that immunotherapies can also be influenced by the immune system. So, in an immunodeficient mouse, you wouldn't be able to determine if the immune system is recognizing your therapy and counteracting your therapy. So, this can be considered an anti-drug antibody scenario, where, let's say, the immune system fights back against the particular immunotherapy, making it less efficient than you thought it would be in an immunodeficient mouse. Lastly, would be the clinically relevant drug response that you could see, let's say, in a mouse with a human immune system versus that of an immunodeficient mouse. In cases where your particular therapy leverages part of the immune system, then of course it may not function as intended or as well in an immunodeficient mouse where there is no immune system to leverage, as opposed to one with an immune system. As you can see from the graphs here, where there's a strong effect of a particular therapy, in this case monoclonal antibody therapies, in humanized mice, but not in the immunodeficient NSG mice. So now I'd like to take this chance to talk about a paper using humanized mice in the context of anti-tumor potency using PD-1 and TIGIT co-targeting in relation to CD56 positive NK cells and CD8 positive T cells. So in solid tumors, the exhaustion of immune cells is very common. This is because the tumor mutates in such a way that enhances its own survival by secreting certain factors that would reduce the efficacy of immune cells in the tumor microenvironment. So in conventional mouse models of, let's say, hepatocellular carcinoma, patient-derived xenografts, HCC-PDX mice, for example, there are limitations in studying this particular phenomenon due to this particular reduction in the amount of NK cells infiltrating the tumors. So you cannot see whether exhaustion is going on because the NK cells do not infiltrate the tumor. So in this particular study, a single administration of an AAV carrying human interleukin 15 allowed the researchers to investigate the effects of the tumor microenvironment on NK cells. So by administering the human interleukin 15, the NK cells were able to be enhanced to sort of infiltrate into the tumor for the researchers to allow this particular investigation to occur. So the mice used in this particular study were injected with hematopoietic stem cells to develop the humanized immune system, followed by the injection of patient-derived cancer cells to develop this human-specific hepatocellular carcinoma, and followed by the injection of interleukin-15 to enhance the activity and numbers of NK cells, as well as T cells. So this allowed the NK cells and T cells to better infiltrate the tumor and allowed the researchers to understand what goes on in the tumor microenvironment. Lastly, they observed a co-therapy mediated effect of the IL-15. So when they administered PD-1 and TIGIT antibodies to treat the tumor, they noticed that the NK cells and T cells were likely responsible for the effect that they saw. They first started off by understanding whether the NK cells are functionally active in these particular mice. So they isolated the NK cells and the T cells to sort of understand whether the NK cells, even if they are there in the human immune system, it does not necessarily mean that they are functional. So they first tested the function of these particular NK cells by comparing it to human peripheral blood mononuclear NK cells. So these were taken from a patient, And they compared the effect by stimulating the release of cytokines in the NK cells. So they observed that it behaved very similarly to that of a human patient. So this sort of allows them to draw the conclusion that it appears to be functional, at least in this regard. So subsequently, they also demonstrated that there was an increase in NK and T cell populations in the mice that were injected with interleukin-15. So they profiled the tumors in the PDX mice for the presence of NK cells and T cells. What they observed is that in mice injected with interleukin-15, they had much higher levels of CD56 positive cells, which is considered to be correlated with the presence of NK cells, as well as CD8 positive cells, which are also an indicator of T cells. So this means that the conclusion from this part is that they observe more NK cells and T cells in the tumor microenvironment. This suggests that there is a higher level of infiltration by these cells into the tumor microenvironment. Next, they took a look at what happens to the NK cells and T cells in the tumor microenvironment. So, as mentioned previously, immune cells in tumors often undergo exhaustion. And so, because of the exhaustion, they are unable to carry out their function as well as they would be if they were not exhausted. So, in figures A and B, NK cells and T cells, respectively, express certain markers that are indicative of exhaustion, such as KLRG1, PDCD1, TIGIT, and LAG3. So, based on the exhaustion score that you can see, there are populations of NK cells and T cells that are more likely to be exhausted in response to this tumor environment. And so, because of this exhaustion, it gives a better picture of whether your therapeutic would be able to be effective because of the exhaustion or not. And lastly, they took a look at interleukin-15 mice in relation to currently existing antibody therapies, such as anti-PD-1 and anti-TIGIT combined therapy. So they demonstrated that interleukin-15 mice demonstrates higher increased interferon gamma production in response to both the PD-1 and TIGIT therapy. This can be seen in figure B, suggesting that there is a stronger response only in the combined therapy. And when they administered the PD-1, TIGIT, and PD-1 plus TIGIT co-therapy every 2 weeks at 5 milligrams per kilogram for 8 weeks, they observed a significantly reduced tumor size only in the combined therapy group, but not in the individual therapies. In order to demonstrate that this was mediated by both the NK cells and the T cells, they depleted the CD8 cells and CD56 cells to understand if there was an effect that could still be seen. So there was a significant difference between the co-therapy treated with and without the CD8 or CD56 cells. So this suggests that the effect that's observed through the PD-1 and TIGIT therapy is likely due to the presence of both the CD8 and the CD56 cells. So in summary, this paper shows you that the humanized immune system is quite valuable for understanding whether your therapy is working or not within the particular immune system context. Because tumors and immune responses can vary very differently in immunodeficient mice versus human immune system mice, it needs to be considered within your drug discovery pipeline, for example, whether it would be worth investigating your therapy in immune system mice or not. So the therapies can be investigated for additional reasons for lack of efficacy, as seen in this paper, due to exhaustion or lack of infiltration, as well as some of the treatments that can be developed can target some of these mechanisms to enhance their potency of therapies, for example. So now I'll talk a bit more about the applications of the humanized mice in oncology. As seen from the paper, investigating the tumor microenvironment is just one of the applications that you could carry out with humanized mice. So at In Vivo Cube, we are one of the few companies that offers humanized immune system mice with an improved human immune system through our proprietary technology. What do I mean by improved human immune system? So by supplementing certain cytokines to the mice at certain timings, we can adjust and modulate the presence of immune cells, such as myeloid cells or NK cells, if you are interested in a particular immune cell type. So this is using a non-transgenic approach to express the cytokines, as opposed to other mice that might use transgenic approaches. So the benefit of using a non-transgenic approach is that it's only transiently expressed. This means that you don't have unintended side effects from the, let's say, cytokine or particular factor being expressed throughout the entire life of the mouse. This also means that whatever effects that you see will not be confounded by this particular transgenic issue. So in vivo cube, we have the myeloid improved mice, which improves the overall reconstitution of immune cells, including both T cells and monocytes, as well as an NK improved version, which is supplemented with IL-15 to enhance the percentage and levels of NK cells. In addition to the human immune system mice, we also provide mice that have both that are able to be engrafted with human patient-derived organoids or patient-derived cells. So this allows you to study specifically that particular patient tumor or cancer in the context of a human immune system mouse. This allows you to develop more targeted therapies as well as personalized medicine that focuses on this particular tumor. This is useful for identifying if there are any subpopulations that might be responsive to this particular drug, or a lack of response to a particular drug if this particular patient subpopulation does not express a certain biomarker. So we characterize to a certain extent the biomarkers in the organoids. And from this particular database, we provide the characterization data of the patient-derived organoids for researchers to develop PDO-X mice, for example. We also offer the possibility of using cell-derived xenografts in human immune system mice. So these would be common cell lines such as NCLN87, NALM6, or BXPC3. So in vivo Q is also able to carry out experiments that will allow you to test if your therapy is, let's say, efficacious in some of these common cell lines, for example. Furthermore, there are certain applications in oncology that human immune system mice would be relevant for, such as looking at whether your therapy is able to recruit the respective immune cells. Let's say in T cell engagers or NK cell engagers, this would be particularly important for testing if your therapy is able to engage these cells, for example. If there are any therapies that are able to modulate the cells in a certain way, like for example, within the tumor microenvironment, human immune system mice would be very good for this particular purpose. So you can also study the tumor microenvironment if your particular therapy is able to either penetrate or study if, let's say, the tumor infiltrating lymphocytes or cells are able to carry out their effects on the tumor. And this gives you a better idea of the human-specific cytokine expression because of the particular response to this tumor, for example. And as mentioned previously, it's also possible that your therapy might be targeted non-specifically by, let's say, the immune system. So this would be of interest to test whether it would function properly, or if it has a reduced efficacy because of the immune system when you bring it to the clinic. And if you're interested in looking at metastasis or whether the tumor would be able to metastasize in the presence of an immune system, then the human immune system mice would also be able to allow you to study this particular case. Another aspect that is of concern is during CAR-T administration, there is a possibility of a cytokine release syndrome. This is when cytokines are released in excess amounts, causing unwanted side effects and discomfort for the patient. This happens with, let's say, CAR-T administration, but in immunodeficient mice, you wouldn't be able to observe, let's say, this particular immunotoxic effect. But when you bring it to the patient, you may encounter this if you did not test for it during the preclinical phase of your drug discovery pipeline. And lastly, you can also use these human immune system mice for HLA-matched immune response. Because we characterize the human immune system mice to a level of HLA levels, we are able to either match or, depending on your use case, provide matched or unmatched HLA immune system mice in relation to your particular use case. And lastly, I'd like to conclude this webinar by presenting a perspective and a conclusion on humanized mice in the field of oncology. So traditionally, immunodeficient mouse models have certain limitations. They do not fully recapitulate aspects of the tumor in response to, let's say, an immune environment. And this prevents, let's say, results of drug therapies from being fully translated to the clinic. So by having humanized mice, it allows you to study the immuno-oncology aspect of your particular therapy in the preclinical stage. So you do not need to wait until the clinical stage, which is generally more expensive, before finding out that your therapy does not work, or if it does not meet the safety profile that you expected it to. So our humanized mice allows you to study with a much greater translational potential. And by modeling the human immune system in mice, you can observe the efficacy, human tumor response, and potential immunotoxic effects early on in the drug discovery phase. This can inform you whether more optimization needs to be carried out on your particular lead compound, or if there are unintended immunotoxic effects associated with your particular lead compound that can be optimized. And lastly, there are many applications for humanized mice in studying tumor microenvironment, anti-drug response, immune cell engagers, as well as HLA-dependent treatment responses. Lastly, I'd like to end off by saying that we are always available for yourselves to contact us at InVivoQ. So we are always open for discussion. If you have any interest in humanized mice, or if you would like to discuss a potential research project, you can contact us at contact@invivoq.com, and we will attend to your inquiry as well. So thank you very much for your attention today, and have a nice day.